Hello everyone, welcome to AOD Care Plan Training. My name is Charlene Kirby and my partner is Karen Fatula. We will be presenting the AOD training for Chandler Hall today. In nursing school, everyone receives training on how to document a care plan. And every day we do implement interventions and achieve goals to resolve issues or problems that our residents are experiencing. Sometimes the challenge is to put those actions into writing. So I wanted to begin with admission care plans. We currently have 6 care plans listed here, and these are priority care plans that are listed. The admitting nurse is responsible for completing the resident's care plan in its entirety. I do not want to relieve them of that obligation or duty, but we have came up with a plan in the event that life happens, as it often does, and the admitting nurse is not able to complete the care plans in its entirety. 2 care plans are required per shift per nurse. And the care plans that we have prioritized are skin, ADLs, continence, primary diagnosis, falls, and pain. Our challenges begin with the new admission care plan, but they don't end there because we have new orders on a regular basis. Incidents occur occasionally, and the level of care for the resident will change, whether it is an improvement or a decline. And all these things matter when it comes to the care plan. So I know that time is limited, especially when you're providing patient care. But nevertheless, these things are a priority. And according to the new federal regulations, every new admission has to have a care plan within 24 hours. In addition to, all care plans must be reflective of the resident's current care. There's no room for error in this area. So therefore, when orders are taken off, not only are they noted in facts, but they are also updated in the care plan when it is pertinent. Also, a call should be placed to the RNAC and a voicemail left if there's something that needs to go on the master care log, in addition to writing on the current care log for the CNAs and informing them of the care change. In order to ensure a continuum of care and to make sure nothing is missed week to week, please utilize the extensions provided: 2264 for Karen Fatula, 2257 for Charlene Kirby. Thank you. Let's review a few specific changes that we want everyone to be on board with. Drugs should only be listed as the category, and the diagnosis in which the drug is being given should be listed. Do not list the name of the drug in the problem, goal, or intervention, because these things often change. But do document the name of the drug and the specific dosage and intervals given under evaluation. This ensures that the care plan is specified and that everyone is aware of the current plan of care. So you may ask, why are we reviewing specific scenarios? These are some of the scenarios that we found during our last survey window. Hydration amounts, if they are specified, such as 1000 cc fluid restriction per day, should be care planned. But it should not be broken down into shifts. And if someone has a history or a current UTI, We want to encourage fluids, and it should specify just that. Generally encourage fluids, not encourage 250 cc's per shift. Many may not have been aware that we are able to input a date for intervention to drop off a care plan. So 3-day voiding trials should be DC'd after day 3. Every hour checks on new admissions at HS should be DC'd after the 7-day interval. IV fluids, IV antibiotics, or anything that has a specific time frame should not remain on the care plan indefinitely. Here are some common errors many nurses make. When doing an electronic care plan, they often select all of the interventions without reading them and ensuring that the details are pertinent to the resident's care. They open up new care plans because an incident occurred instead of updating the current care plan that is applicable for that incident. Foley catheters, according to our Kendall Corporation audit, requires both a catheter care plan and an infection control care plan. I don't believe many of us are aware of that. So moving forward, please note any Foleys must have both care plans. And many nurses forget to notify the RNX to modify the master library in the event that there are interventions that we do not use available or interventions that we should use that are not available. Thank you. So it's practice time. We have 4 scenarios. Each nurse will be assigned a scenario to develop a care plan. Number 1, add the appropriate care plan for a resident who has a new skin tear. Number 2, add the appropriate care plan for a Foley catheter. Number 3, add a new care plan for anticoagulant drugs. Number 4, add a new care plan for a diabetic type 2. We will pause the video to allow approximately 5 minutes for each nurse to complete their care plan. Here is the background information of a new admission. I would like every nurse to list the potential care plan problems for this scenario. A resident was admitted with a diagnosis of pneumonia. He fell at home after he became short of breath while attempting to walk up the stairs. He was found in a pool of urine by his wife 10 minutes after his fall. The ambulance driver helped him up off the floor. We'll pause for a few minutes to allow you to create your problem list for this resident. Here are a few problems for the new admission scenario we just reviewed. Alteration in respiratory status, respiratory infection, safety or falls, continence status, and functional mobility may be areas of concern. Now I would like for you to share your concerns if you have anything that is different than what's listed above. Our goal was to ensure everyone felt confident in completing care plans, updating care plans, and in the event that your questions or concerns have not been answered, this is the time for us to have an open discussion about what to do concerning care plans. Thank you.